Right, good morning, everybody. This is great. We are actually starting the meeting on time. I'm delighted to tell you. My name is Cecilia Motley. I'm the chair of the Health and Wellbeing Board, and I'm also the portfolio holder for adult social care and public health for Shropshire Council. Before we start, I should just say that the meeting is being live streamed and recorded, and members of the public will be able to see this meeting and hear the audio. So if we just start, I think by going around the table and getting everybody's names, role, excuse me, role and organisation. Start with you, please, Rachel.
Thank you. Good morning. Rachel Robinson, Director of Public Health in Shropshire. Penny Mason, Head of Joint Partnership, Shropshire Health and Wellbeing ICB in Shropshire.
Good morning, Nigel Lee, Chief Strategy Officer for the ICB and also Strategy Partnerships.
Hi, I'm Tracy Jones. I'm the Head of Health and Equality for Shropshire Health and Wellbeing Integrated Care Board.
Good morning, I'm Lynn Corley, Chief Officer at the Health Watch Shropshire.
Naomi Roach, Public Health Principal, Healthy Population Lead, and Shropshire Telford American Women's Health Lead.
Michelle Dulson, Committee Officer for Shropshire Council.
Louise Jones, Business Support Lead for Shropshire Council.
David Crosby, Chief Officer for Partners in Care.
I'm Gordon Coshane, Public Health Consultant for Shropshire Council.
Good morning, Tanya Miles, Executive Director of People, DC and Staff for Shropshire Council.
Thank you all very much. Online we have
Mel.
France.
Yes, morning everyone. So I'm Mel France. I'm the Public Health Principal for Integration and Inequalities at Shropshire Council.
Thank you. Below you is Laura.
Morning everyone.
Oh,
Go on, Laura T. Go on.
Start with Fisher and then go up to Tyler.
Sorry, Laura. Laura Tyler, Assistant Director for Joint Commissioning for Shropshire Council and Shropshire Telford and Wellbeing ICB.
And Laura Fisher, I'm Head of Housing, Resettlement and Independent Living at Shropshire Council.
Right. And then Philip.
Hi there, Phil Norfield's Public Health Development Officer, Integration and Inequalities.
Lovely. Thank you very
Peggy
much.
is on the line as well, I think. Peggy Mullock.
Oh, Peggy, are you there? Hello. Peggy?
Hello.
Hello. Would you like to tell us who you are, Peggy?
Sorry, Peggy Mullock, and I chair the scrutiny for people. I'm sorry, I've got COVID at the moment, so I'm not very good.
Well, it's very good of you to join us. Thank you.
Okay, I'd like just to listen in if that's okay.
No, that's absolutely fine, of course.
Okay.
The only one, I think that's it, isn't it? Yeah. Yep. Okay. Thank you all very much. Right. Gordon. I hardly recognised you. Good morning. Right. We've had apologies from Patricia Davis, Chief Executive of Shropshire Community Health Trust, Claire Parker, Director of Strategy and Development at the ICB, Zafar Iqbal, Associate Medical Director, Target Health, MPFT, and Simon Whitehouse, CEO of the ICB, who is also co-chair of this committee, and I think will be chairing the November meeting. So that's good.
We've also had apologies from Paul Wilson. I know a number of people, I think, are unwell at the moment with COVID and various things.
Yeah, I couldn't,
including Mel.
Okay, right, all right. Okay, thank you for that. Now, please, could I ask that any members who have a disclosable pecuniary interest, which isn't already recorded in the register of interests, leave the meeting prior to those items being discussed and disclose those before they go. Thank you. Anybody? No, that's good. Right. Minutes of the last meeting. Has everybody seen copies of the minutes of the last meeting? And are you happy with those minutes? Are they a true record? Are there any amendments which anybody would like to make? No? Okay. In which case I can move now that the minutes of the Health and Wellbeing Board meeting held on the 16th of July be signed as a correct record. Could I have a seconder for that, please? Thank you, Rachel. Seconded by Rachel. And I'd like to move that these minutes be accepted as a true record, and I will sign them afterwards. Right. Moving on. Public questions. We have no public questions today. So we can move straight on now to the strategic items, reports for discussion. And this first one is the suicide prevention strategy update. And we've had, as you will probably recall, the Suicide Prevention Awareness Week. And Gordon has been very much at the forefront of promoting this and researching it. So, Gordon, would you like to?
Right, okay, I shall do that. Which one is it?
Go the Teams link there. No.
This one.
And through that. Share menu this one. That's great. And that will come from
Okay, apologies for the delay there, and thank you for the introduction. And so today an update on our suicide prevention work in Shropshire. And also, before we begin as well, just to formally thank Councillor Motley, our Samaritans, Shropshire Mental Health Support, and all our other partners who supported the World Suicide Prevention Day and the promotions during the week. And really important that we do get the messages out there, encourage people to talk about suicide, raise awareness of risk and what support is available. We really do want to encourage more people to feel confident and comfortable speaking about suicide and suicide risk to address the stigma that's often associated with it. So as a starting point, I thought it might be helpful to look at the latest data and the intelligence of what's happening in Shropshire. So earlier this year, we had some data published from OHID fingertips, which indicated that the local suicide rate in Shropshire during the 3-year average 2020 to 2022 had increased above the England average. This opened up, obviously, a whole range of discussions by our action group, and we were really keen to understand this. We recognised this occurred during the period where COVID and the lockdowns and a whole range of other global issues were occurring, and obviously really needed to unpick that. Now, a few weeks ago, there has been an update to the data, which is now looking at the 2021 to 2023 period. What that indicates is the Shropshire rate has now reduced and slightly, so we're now statistically similar to the England average. So our local rate for that period 2021 to 2023 is 12.8 suicide deaths per 100,000 people. That's in comparison to the England rate of 10.7. So it's still higher than where we want to be, but at least it's positive that it has reduced. Nonetheless, all of the actions, all of the priorities that the action group are working towards are absolutely still relevant, and we'll come on to those in a moment. So I just wanted to give an indication of where the Shropshire suicide rate sits in comparisons to other local areas in the West Midlands. We are rated, if you will, the third highest in the region. However, I also wanted to demonstrate how we compare to our statistical neighbours. So these are local areas across England which have similar demographic or geographic profile to Shropshire. And what you can see there is we're middle ground, if you will, in the middle during that period 2021 to 2023. So again, our opportunity from this data is to think about what's happening in the areas where the rates are higher, what learning can we potentially apply from what they're doing, and helps us with our local planning and priorities as well. But again, it really emphasises the need for all of us to be suicide aware, to have that understanding of our role in supporting those with thoughts of suicide and connecting to appropriate support. So as an initial response to that data from earlier this year, an exception meeting was held of the Shropshire Suicide Prevention Action Group, and a number of activities, immediate priority activities, were undertaken. The first, as I mentioned, was better understanding of what was happening during this period. What do we know about the circumstances of these suicide deaths? So we undertook an audit of coroner inquests from confirmed suicide deaths throughout that period. This is still being reviewed by the action group. However, there are some initial headlines that I will be sharing with you in a moment, focusing on the quantitative. There's still a lot more to pull out from the qualitative and working with partners, again, to explore opportunities of any priority actions that could be moved forward. We also wanted to review our real-time suspected suicide surveillance system. So just as a reminder, this is a platform that Public Health is working with the police and our Mental Health Trust to identify where a possible or probable suicide has occurred in the community. And this is prior to the inquest. So that's why it's possible, probable. But the purpose of that is to understand, are there any emerging themes or trends or things that are happening within our community that could benefit from a more immediate, preventative or targeted response? So in terms of the enhancement, what we were really keen to do is to expand the number of partners and teams that we're working with to collate that intelligence. So we have started now working with our housing team, social care team within the council, our domestic abuse service, Shropshire Mental Health Support, our drug alcohol provider, Shropshire Recovery Partnership, as well as a few others. They have been trained in using this platform, and the purpose is to identify where that possible, probable suicide case is recorded onto the system if they were known to other services. And again, this helps us with our conversations and thinking about what could be potentially beneficial across our services to identify and respond sooner. The data has just started to be added to that. So in terms of the intelligence, we do need to wait 3 to 6 months to really make best use, just to caveat that. And we're also really keen to establish a new process for suicide death review panels. So taking learning from our drug alcohol death review panels, and we are hoping to have a tester of this panel, and that would involve wider partners as well, before end of calendar year. So the process is being designed by our action group and with partners at the moment. So just in terms of some initial messages from the audit, in summary, there's nothing, shall we say, different to what the national evidence demonstrates in terms of suicide and suicide risk. What we did look at was 114 inquests with verdicts of suicide throughout the period 2020 to 2023. Similar to the national data, the most common age range was that 35 to 54-year-old cohort. However, again, what we need to be clear when we look at this data is this is data around deaths. What we don't have is data on suicide attempts or thoughts of suicide. And this is something the action group is exploring with our partners, how we can capture that intelligence in a more systematic way, recognizing it is a challenge, recognizing some of that can be subjective, but absolutely valuable for us in terms of our preventative actions. One of the other key things that was identified is that when looking at usual residents of those individuals who died by suicide, there was no difference in terms of areas of deprivation. So once again, it reinforces that point that suicide is a society problem. It can affect any one of us anywhere. Thinking about socioeconomic aspects, half of the inquest reviews that we looked at were people who were in paid employment of some form. However, a quarter were of retirement age. And again, really important for our priority actions, thinking about how we engage with our older residents across the county and what we can be doing in perhaps different or more opportunistic ways. And thinking about sectors in particular, the themes that were coming through, well, as you can see here, are agricultural, forestry, fishing, building and construction, professional, scientific, technical, that's our managerial and professional cohorts, and the health sector. So again, in terms of some targeted work from an industry perspective, useful for us to understand. And again, it does actually align with what's being seen nationally as well. Some of the initial risks and life events thematically that were identified, perhaps again, unsurprisingly, this does relate to national evidence as well, is actually having a previous suicide attempt and self-harm attempt, particularly in that 12 months prior to death. Relationship breakdown, a really common theme, and that covers a whole range of different types of relationships, family, partner, many situations. Bereavement was a very common theme, and a whole range of others there. And the purpose of this, again, it emphasises that suicide prevention can't occur by one group in isolation. It is all our responsibilities, and it does require all of us who have that opportunity to connect with people ultimately, but particularly from the themes here, how we can ensure that those who are providing offers of support that that connect with these themes, do they have the right access to skills, knowledge, training? And we do have some offers to support that as well. And another key theme there, again, however, not as well recorded, but absolutely adverse childhood experiences was something that did present in quite a few of those cases. And also contact with services. One of the areas we were keen to look at was what was the last contact that individual had with statutory services. And again, similar to the national evidence, GP was the most common. Now, what we've been looking at as Shropshire, Telford and Wrekin and Suicide Prevention Network is the production of a GP suicide prevention resource toolkit. The purpose of that is to support GPs and potentially wider primary care in having those conversations if somebody does present with thoughts of suicide. The use of language, how to have that engaging conversation, how you can bring in potentially that person's network, creating a safety plan. So it's we've created this with our two named GP safeguarding leads across Shropshire, Telford and Wrekin, and hoping for this to be launched in October, if not, well, it probably will be October now. Okay, so now I just wanted to move quickly on to updates around delivery of the strategy. So most of this will be in the report I submitted, so I'll go through relatively quickly so we can have time for any questions. But just as a reminder, there's 4 overarching objectives within the strategy, and that is around improving data and intelligence, improving outcomes for those who have been bereaved and bereaved by suicide or unexpected death, ensure that we have a suicide-aware workforce, and how we can enhance those offers that mitigate suicide risk and that more targeted approach to the more vulnerable and higher risk cohorts within our communities. So I've spoken a bit about some of the data already. I did want to highlight also that we do have a new real-time surveillance coordinator that works across Shropshire, Telford and Wrekin, which again helps us with that expansion of the surveillance system and has been really helpful. So that person may be in contact with your team or service if they haven't already, to support us going forward with this work. In terms of improving outcomes for people bereaved by suicide, I just want to remind the board that Shropshire, Telford and Wrekin were one of the first local areas to establish a suicide bereavement service, and it is now well established. Just as a snapshot, during 23-24 for the Shropshire specific side, so the Shropshire Local Authority, we had 75 referrals into the service. We are continuing to promote the offer. We do have a new bereavement officer that's joined recently, and they are keen again to connect with all of our services, our teams and offers throughout Shropshire, Telford and Wrekin to introduce themselves. So if you haven't had an opportunity to speak to our suicide bereavement team, please do. They can explain what the offer looks like, how to access it, and if you're working with anyone that potentially could benefit. We have also established a pilot programme working with one of our voluntary sector partners, Crane Quality Counselling, for providing a counselling offer for people who have been bereaved by suicide but are struggling themselves. So a great opportunity again to explore different ways of working, and again encourage partners who are aware of anyone that potentially could benefit from that support to please reach out. We have also established 2 survivors of bereavement by suicide peer support groups in Shropshire. So these are currently based in Shrewsbury and Oswestry and are available for any adult who has been bereaved by suicide and would find the opportunity to speak about that with people who have been through a similar experience in a professionally managed and safe environment. So again, further details of all of these offers are available on our Healthy Shropshire webpage. I've just put up here a few comments from clients who have accessed our suicide bereavement service. But it's always helpful to have that human touch of how people have benefited or found it helpful. And we'll share these slides afterwards. Okay. So in terms of promoting suicide risk-aware workforce, so we've been very fortunate over the past couple of years to have access to a dedicated suicide prevention budget, and this has allowed us to promote and deliver suicide prevention training, some of which is subsidised or free to access to some cohorts, and particularly those who either don't have usual access to a training budget or who have that frontline reach to our most vulnerable communities. So this has been delivered by our joint training team, but we're also working closely with the national charity Papyrus, who support with children and young people, young adult suicide, and they offer some fantastic training, and we do have access to, again, some subsidised offers for that training until end of calendar year. But just to give a flavour again, for Shropshire during 23-24, we had 200 people from across services, from the voluntary sector, from the community sector, who have accessed suicide prevention training. And I won't go through all of them, but there's a snapshot of some of those organisations and teams presented there. And again, we want to continue promoting this. We want to continue raising awareness, ensuring that people do have the right skills and knowledge to respond to suicide risk. And also that does continue with our promotion of the Zero Suicide Alliance free to access training. And that is for anybody. You don't need to be a mental health professional or work specifically in suicide. It's for anyone who has interaction with people. So all of us really. And just I put it on there as well. We have worked with our licensing team to build in suicide risk awareness training for our taxi drivers as part of their safeguarding awareness program. So that started earlier this year and so far seems to be positively received. And that also includes providing physical copies of our Pick Up the Phone, You're Not Alone resource, which provides first point of contact of who you could support or who you could contact, sorry, if you are having thoughts of suicide. And on this slide, when it loads, that's a snapshot of the different training programs on the Zero Suicide Alliance website. It might be a little bit small there, but they generally take about 20 minutes and they range from the broader suicide awareness training offer to more specialist areas, including autism and suicide awareness, veterans, working with veterans, the taxi drivers. There's a version specifically for those who are working in criminal justice and prisons. There's a Welsh edition, and there's also probation and a university student. So a good range, and I really would welcome if the board could support the action group to promote this free online training. And continuation of the work that is to mitigate suicide risk and targeting higher risk groups. So one of the areas that we were keen to do is establish dedicated work streams that can bring in stakeholders who already work with higher risk vulnerable groups to not duplicate what's already happening, but what can we do to strengthen those links and work in a more integrated way with either what's already provided or to think about where could the opportunities be to address gaps and think about, again, from a suicide prevention perspective. So as an example, we've had work groups already meet on people who are known to services and what the statutory or voluntary sector response could be when they are working with somebody who is presenting with thoughts of suicide. Men as a cohort, we know men have that greater burden of suicide when looking at rates in society. So what can we be doing differently that encourages men to talk more openly about mental health and suicide? Our rural communities and our farming communities, and that link with what's been delivered through our health checks with the farming community and establishing other opportunities to raise awareness and support. And next week, we do have a dedicated theme on children, young people and young adults. So again, if anyone would be interested in being part of that conversation, please do reach out and I'll share the details. And just as a final slide as well, this is more promotion, the universal offers, if you will. If you are aware of anyone struggling with thoughts of suicide, these are great resources that can provide guidance or you can signpost to. And as I mentioned, we do have our Healthy Lives Shropshire webpage, which has links and information on there also. So there is a lot more that's happening, but happy for any questions if people would like.
Gordon, thank you very much indeed for that. I'll throw it open for discussion and question, but I represent a very rural division. Everyone gets fed up with me saying that, but it is a fact that we do have, I would suggest, relatively higher rates of suicide among the farming community, or not necessarily the younger members of the farming community. Sometimes it's the older, it's the retired members of the farming community. There is a strong sense of isolation around suicide, isn't there? There is a very strong sense that there's nobody around who is interested or who's going to listen. And therefore, people will very often just tuck themselves up and won't discuss it at all. And it seems to me that, of course, one can have out there all sorts of methods of trying to contact people who may be feeling suicidal. but I wonder whether you have found what normally is the first point of contact with people who are feeling like that, because it seems to me that the work that's been going on to engage with the farming community through the Shropshire Rural Support, visits to the livestock markets is a good starting point. But a lot of people just don't know where to go, and the farming communities, are not good at going to their doctors. So I just wonder whether you have any insight into that.
Yeah, and it's something that we are exploring with those who work with the farming and rural community. So, for example, the suppliers to farms, the animal vets, and thinking about who are the usual contact points that our farming communities and rural communities would engage with on a regular basis. So we are continuing to explore how we can promote those offers, the training, and recognise it can be challenging because of time commitments and other things as well. But to look at how we can work better to arrange our offers of awareness raising, of what support's available, and to understand more from their perspective, actually, what would you find helpful? What would encourage you? And I think encouraging speaking in the first instance and feeling able to speak is a good starting point. But absolutely, it takes a lot of work. It takes a lot of trust building. It takes a lot of tricky. Absolutely.
To actually express the way they're feeling.
Absolutely.
Thank you for that, though. That's helpful. Yes, Lynn.
Thank you for that, Gordon. As you know, this is a subject that I'm really, really passionate about. So just a few comments from me. In terms of that reaching out, I suppose my thought is that I think there's a lot of people out there who are worried that if they share their thinking, that people may overreact and then they would lose control over decisions, their life, in order to be protected. So I think there's something about, and I think that may be particularly important for men. That idea that if you say to someone you're thinking of taking your own life, that all of a sudden you may be committed or you may be, sectioned under Mental Health Act. So I think there's a lot to be done about information sharing, but also that acknowledgement that so many people have those thoughts. It doesn't necessarily mean that they will commit suicide, but it is actually a sign of a bigger challenges. The other thing I was going to say was 2 years ago, I started a piece of work to do a piece of engagement around menopause, and I spoke to people from across our system, from MPFT, from GPs, and I think something that I think was missing here was the potential link with menopause. And I know that MPFT have looked at that, so I would suggest that is a group that maybe is looked at as well. And then the other thing I was going to say, sorry, I've got a few things. This is my colleague Diane Drummond, so she's just joined Health Watch as our interim view officer and ICAS coordinator. And together we're picking up on some work we've done previously with Stoke Heath Prison. Now, this is a prison where when I went, the nurses working there told me that quite often people were saying that they were going to kill themselves when they were released from prison. And because of how systems were not able to respond, some of those men were successful, and we sort of linked them in with public health. But they have a group of prisoners called Hawks, who are the health and wellbeing champions, and they're trained to support other prisoners while they're in prison. And so I just wondered if they were aware of all that free training that's available, because they could be really instrumental in helping people prepare for release. Because for a lot of those people, that probation link might be too late. They've already made that decision before they're released. And then on a personal note, a family friend of mine, a man had a cancer diagnosis and he committed suicide this year. So there are an increasing number of cancer support groups for men, which I'm hearing all about because I'm writing our report on living with cancer in Shropshire. And so I think that there's probably a route in there as well for information, but also training on how to support men to deal with that diagnosis and their prognosis. Yeah.
Thank you for that. Actually, some really great suggestions there, and would welcome a follow-up conversation for connections you have, and absolutely recognise what you're saying there as well around cancer and other physical conditions, and that's one of the themes that did come up from our audit as well. So yes, please, if we can have that conversation, I'd really welcome it. Thank you.
Great, thank you, Lynn. Nigel.
Thank you very much indeed, and gosh, that's such an important topic, isn't it? A couple of questions and then a couple of offers, if I may. I think the first one is, would you be able to, because I don't think the slides with the pack, are you going to be able to share those?
Yes. Sharing them now, Nigel.
Oh, fantastic. It's just that things like links and whatever, I think there's, as you were talking, and Lynn reinforced some of them, that there's a few groups I think that might be useful. Two, probably with my SAF hat on initially, and actually I can put you in touch with our lead cancer nurse who does, and under that there's quite a lot of those sort of support groups, and we work obviously closely with Macmillan and others. So I think there's a set of tentacles there that we can use. My question was, in terms of the partners, I didn't see the ambulance service, and that might have been just because there was a whole list of, and therefore it wasn't necessarily an exhaustive list, but they feel like an important
yes,
one.
Absolutely. So we are very willing to work with our ambulance service, but recognise that it can be challenging for them to send a representative to our action group. So if there is a contact that perhaps we could be linked to have those conversations, absolutely, it would be a very valuable partner for us to connect with.
I'll try and dig out one. And the other one was just, and obviously you mentioned the armed forces side. Certainly from a trust perspective, and certainly just knowing from SAF and as an ex-armed forces myself, there is actually a real, we were trying to increase the momentum, and Sarah from the council, we had a specific armed forces day just at SAF yesterday at the two sites, and a whole range of different partners supported us. I was at Shrewsbury, Sarah from the council was there, did a lot of the outreach, a number of the different support teams, volunteers for Help for Heroes and others. But we also have a set of armed forces champions across the hospital. So if I'll send you a drop your note, Gordon, because we're trying to push the veteran away a bit. But we've got obviously then another set of people, and I think your aim, you can see that what you're trying to do is just make sure that more people are aware. I think it's another sort of, again, if it's a slightly less formal network, will probably really quite important. But thank you.
Yeah, that's fantastic. Thank you very much for those offers. And again, we want to reach as many people as we can. So anyone who has suggestions or aware of other groups that we can connect with, please let's make that happen. Thank you.
Thank you very much, Nigel. That was very helpful. Rachel, and then Penny.
Thank you. And I won't repeat everything that everybody said at partners. I think it's fantastic to bring this back to the board. The point you've made over and over again around the collective ownership, and it's great to see that happening, those connections and all of the topics we're going to talk about today, but you can see how critical it is that everybody owns this and we get those messages out. On that vein, I think in terms of as a board, previously we've all committed to the zero suicide prevention training. I probably think it's a chance for us all to refresh that. If maybe it's a small recommendation I would suggest, and also how can we take that through to our relevant boards and make sure that actually everybody has had that training and awareness, so that we're supporting that role as well. I think it's really important that everybody understands that the issue that comes up time and time again is around knowing what support's available and getting those messages at first point of contact, and just being aware. And I think that's something we can all promote, and we can't cascade far enough the messages. Obviously public meeting, public listening, knowing that support's there and where to go. But I think also that training maybe is an additional recommendation. Colleagues are happy to accept that.
And if I can just respond, I was going to just bring it in right at the end, but it might be opportune. We are offering a bespoke session of suicide training for our members, our senior officers, and for the Health and Wellbeing Board as well, which will be taking place on the 26th of September, 5:30 till 7 p.m. So it would be great if members from the board and our members and our senior officers would have availability to join that. So again, this will be in the slide pack, and I believe some information has been shared as well.
Great, thank you, Gordon. That's online, presumably. Yes.
Yeah, sorry, it's that's online training.
Yeah, that's good. Excellent. Thanks very much. Penny.
Thank you. Just a couple of points. So just back to Cecilia, we're talking about the farming community in particular, and with a lot of effort in connection with the kind of inequalities work that we're doing and blood pressure checks. So we are at the livestock markets, as you know. So a lot of work at the moment, both from outreach team within Shropshire Council, but working in partnership with blood pressure champions and other partners. They, what happens is blood pressure is taken, but it's opportunity for those conversations with the farming community, and we know those conversations are really vital and happening. And I think it's about being able to maintain that work and really doing that in partnership with others. The other thing I just wanted to note, I guess, is that Gordon, you talked about the bereavement, a recent bereavement or a bereavement as a kind of one of the risk factors, and I think, although we have a suicide post-vention bereavement service, which is vital, we also know that bereavement service we have had been about struggling to fund in the long term after the end of 2024, and I think that was available in 2025, 24, 25 around children and young people, but also adults, and it links really heavily to trauma as well. And we know that these are areas that we're looking to develop as a health and wellbeing board. We have the board has really endorsed our trauma work, but also thinking about mental health and how we're able to invest in the prevention of mental health, ill health for children and young people and for adults. And I think we're still not there yet as a system in doing that properly. So I just really wanted to nail that down.
Thanks, Penny. That's very helpful, Helen. Jackie.
So apologies about nipping out before, so in case it's just been mentioned as well. But just a couple of things. When we talk about areas of deprivation linking with suicide, we have to be really careful in Shropshire about, there are very small specific areas of deprivation, but actually socio-economic factors do contribute, but they're not particularly down to ward because of the rural area of Shropshire. And I think we have to be aware of that, and certainly within our debt team that we have at Citizens Advice Shropshire, a lot of our debt clients talk about suicide ideation, and it's a contributing factor. So the offer is we don't have a lot of time to go to action groups and things, and apologies from me. But I think your real-time surveillance worker would be really grateful if we could have that kind of meet up, and then we can give you our data on our safeguarding, and Age UK can as well, because I do think there are well-being and they contribute to that, and the frustration that people that support people who have those ideas of suicide ideation, how we can then hand them over to the crisis team. And that's our biggest frustration, is we never know who we should do. So that would be a really good, because a lot of the feedback we have from our clients is access to services and that. So that would be really great. But it's an offer to make that link, and then hopefully we can feed it you a bit more meaningfully.
Brilliant, and I will accept that offer, so thank you very much. And it's a fair point about the data, and this is a key point I always make as well. The data that we capture is the starting point for conversations. It isn't the end point and the answer, so absolutely recognise that link with financial insecurity as well. Thank you.
Chair, can I just say that Peggy's got a hand up, and if I can ask Gordon to stop sharing so that we can see Peggy, that would be great.
Peggy.
Thank you.
Oh, you don't have to see me. I just checking the date of that training, because the Tuesday's the 24th, Thursday's the 26th. I just wasn't sure which.
It was the 20th. It was the Thursday, wasn't it?
So it's the Thursday then.
Hold on, Gordon's just checking, Peggy.
Okay.
Sorry, can I come in? It is Thursday, the 26th. Can I confirm that?
Okay, that's all I wanted.
So that was a slight oversight. Sorry.
That's okay. Just to be on the safe side. Thank you.
Right, any more questions? Natalie.
Thank you.
Could I just bring the board's attention to the other one? Could I just bring the board's attention to the information that Louisa shared yesterday from the West Midlands Trauma Informed Commissioning Guidance and the Learning and Development Framework? There's a real opportunity. We've been, as a local area, been really involved in informing those frameworks and that guidance, but there's an opportunity for us to influence the kind of system commissioning approach, especially when it comes to trauma and adverse childhood experiences. So there's some really good resources there that we could push and adopt and take on to really try and kind of support our system partners to ensure that their commissioning and approach to commissioning and learning and development reflects those needs.
Thanks, no, that's very helpful.
Claire,
Yeah,
sorry, can I just extend that a little bit further? On that note, there is a trauma-informed workshop in October that we will invite the board to, so just highlighting.
I already have, yeah.
No, I know, but just highlighting it for the board.
I thought there was. That's very good stuff, because we've got to link all these things up, haven't we? Otherwise, everybody's doing things in little pockets. The most important thing is to make the knowledge universal as far as possible. So this is excellent stuff. Right, I have no more questions. So, Gordon, can I thank you very much? We have recommendations following this discussion, which are as follows. First of all, consider endorsement of the activities presented within this update. Contribute and support the continued delivery of the suicide prevention strategy and evolution and delivery of the action plan. Support the recommendation that system partners continue to prioritise suicide prevention actions and promote the workforce to access suicide prevention training to help contribute towards efforts in reducing local deaths, and receive regular updates on progress with suicide prevention activity. If that's okay, there was one more, wasn't there?
Yeah, sorry, that was just in terms of things specifically this board.
Yes.
And the senior boards. That commitment, I think, but as a board to
yes, I think that
training.
That covers it, doesn't it? Right. Okay, Gordon, many thanks indeed.
Thank you.
That was an excellent report. Thank you so much. Right, moving on. So all the 4 keys are behind. Now we move on to the inequalities plan. That's Mel.
I was just going to start by giving an introduction whilst Mel and colleagues will load up the slides and prepare. So first, I just wanted to thank everybody who's taken part in this. This is our inequalities plan. It's deliberately called an inequalities plan, not just a health inequalities plan. It covers the work that we need to do within Shropshire around tackling not only the health inequalities that we have in our healthcare inequalities, but also those wider determinants of health. I know that there's been significant involvement from Phil, who's on the call, Mel, Alex, Mace, who's involved, and Tracy and other colleagues in the room, because this is really a partnership plan covering a huge amount of indicators and with a really strong focus on some of those rural issues we've already been discussing this morning that was heavily dominant in the plan, and rural inequalities and those poor outcomes in those areas. I think it was back in November 2022 that the board first saw this report, and there's been a lot that's moved on in the world since then. The fallout of COVID, which in the last presentation highlights the ongoing work around the cost of living, which isn't going away, and the impact particularly on our population and our rural population. And then I just thought it was helpful to draw our attention to the recent Darcy report that's been published, which is got some really stark reality in that report, highlighting particularly how the health of our nation continues to deteriorate. Not perhaps unsurprising given sort of what we were predicting, but actually really important context. I think the other bit, which and this is why this report's so important, is that social context. So actually, we need to focus on all those social determinants we know and we talk about through, for example, the cost of living work, the impact of housing, employment, and we've just talked about some of those, and is having on people's outcomes, particularly, and we see real inequalities around this. The Darcy report very strongly says that NHS is seeing and facing increasing demand from a society that's in distress, and we see examples of that very starkly. It's not just the NHS, it's NHS and social care, and we can't take the two apart. So that's really important. And I think, again, a lot of the numbers of people living with long-term conditions. So this report, I would argue, is never more relevant in the work that we're all doing in a very challenged time.
And we're going to talk about some of the progress, the significant progress that's been made, but we can't rest back on that. And there's a lot more for us to do, particularly within that context. So I just wanted to give that by way of introduction. Colleagues will go into the detail around this, and obviously I hope we can have a good discussion. But massive thanks to everybody, because again, this is what Health and Wellbeing Board's here for. It's a system-wide piece of work, and I'm glad that this is top of our agenda. Thank you.
Thank you very much, Rachel. Right. Now, Mel, are you ready to go?
I certainly am. Thanks, Cecilia. Okay, so I am going to assume that everyone is familiar with the report. So thanks, Rachel, for that introduction. As you heard me introduce myself at the beginning, my portfolio of work consists of integration and more recently inequalities. So although inequalities has been at the core of my programmes of work, I've not been working at the breadth and depth that this plan covers. So I would just ask that the board give me a little grace as I'm gaining that wider knowledge. But for reassurance, I am learning very quickly. So to put a little context around the report and the presentation, the original plan was developed by Bernie Lee, one of our public health consultants, working alongside Val Cross from the public health team, and also colleagues across the ICS, which includes Tracy Jones, who's with us today. And I will hand over to Tracy to give us a brief overview from an ICS perspective shortly. Although Bern is no longer working with us, Phil Northfield, who is also on the call, who is one of our public health development officers, Phil and I have been working with colleagues at Shropshire Council and the leadership team across the wider ICS to gather the updates that are within the report. I am pleased to say, and I'm sure that you'll agree, there's been an incredible amount of work that has taken place. That is either completed or is on track, and you'll see this visually on the next few slides. So if we can move to the next slide, Phil. Lovely, thank you. So before we show you the results, if you like, I'm sure that everyone in the room is familiar with the definition of inequalities, which you can see on that slide. And we are working together using the population health model, including the wider determinants, healthy places and healthy lifestyles to improve outcomes for local people. As you've heard Rachel say, much has changed in Shropshire, particularly over the last decade. There's a combination of factors and drivers, so squeeze on wages, sustained austerity for public services, and a decreased social security safety net, which has resulted in a year-on-year reduction in household living standards. To add to that, as you heard Rachel mention, the pandemic has had a huge impact and continues to do so. Alongside this, there is a rise of in-work poverty, which affects the whole of the UK, and we've certainly seen that in Shropshire, in addition to a rise in food and fuel poverty. Strategically, we are working together to tackle structural inequality by having a common understanding of language, developing opportunities and understanding evidence and data, which helps us to identify and consider the gaps. So that we're making sure that those most at risk are identified, acknowledged, have a voice, and we are working with those with lived experience. We also take into account that where people live is often a defining factor, particularly on education, employment opportunities, and ultimately health outcomes. Which brings me on to something that Cecilia's already mentioned, which is rural inequalities. I grew up in a remote village in South Shropshire, so I have lived experience of just how impactful rural inequalities can be, both on young and elderly people within our communities, and this should absolutely not be underestimated, and it is a growing concern. For balance, I actually now live in Telford, so I'm also familiar with how inequalities can impact those from urban areas too. What I would say is that in Shropshire, it's not uncommon for these groups to have different drivers, but to be facing similar struggles, such as with housing, with mental health, and accessibility to services that meet their needs. And obviously, we've just heard Gordon talking about one of the initiatives to support this around suicide prevention. Can we have the next slide, please, Phil? So I think this is probably what the board will be most interested in, is the progress that has been made. Tracy will talk through the slides for the ICS in just a moment, but for Shropshire, the next 2 slides, they are a visual representation of the detail that is in the report. So this shows the programmes of work that have been led by Shropshire Council. This one is wider determinants, healthy places and healthy lifestyles, and we have RAG rated them. So as you can see, those rated as green are on track or have been completed. And those shaded grey, we're awaiting reportable data and updates. So we know that there is work going on in these areas, and it's really important work, but we just don't have that reportable data as yet. So Phil, if you move on to the next slide, please. This is the visual for the social inclusion groups. So hopefully you will have seen in the report that we've noted 54 of the 70 actions that we expected across the plan have been completed or significantly progressed since the plan was developed, which I think is really noteworthy. I mean, it's a fantastic achievement against Shropshire Council and the ICS. So the next slide, so the next 5 slides are Tracy. So I'll hand over to Tracy to talk through the ICS, and then I'll round up at the end. Thanks, Tracy.
Thank you. So we just thought it would be helpful that we introduced or reintroduce, for those of you who are aware, the core agenda within the NHS healthcare inequalities arena. So the core 20+5 is a concept that has been spoken about quite a lot across Shropshire, Telford and Wrekin since the introduction of the plan. It's a national NHS agenda, and it looks to the areas that we know have the worst health outcomes. So first of all, the first part of that is the core 20%, and that talks about the 20% most deprived areas. And for those who aren't familiar on how that deprivation score is calculated, I just want to share that it's actually a multiple indices of deprivation. So it will take into account factors such as income, employment, education, crime, housing, health, and also living environment. So it's a whole collection of factors. We know that when we look at health outcome data, individuals who are living in this core 20% have the worst health outcomes. We then have the plus groups, and this is where for us, especially in Shropshire, we can see the impact of things like rurality. Other plus groups, and these are growing groups here within Shropshire, Telford and Wrekin, are people who are made vulnerable by their immigration status, people who are sex workers, homeless, rough sleepers, and those who have contact with the justice system. So we know those are a widening plus group of individuals. And then we have the 5 clinical areas. And these 5 clinical areas are the areas that data has shown that we see the most difference between those with good health outcomes and those with less well health outcomes. So those are the 5 for adults. And then the thing that goes across all of those, and it's really, really important, is smoking status. Smoking cessation is one of the key factors that really impact on people's health outcomes. And we see that smoking is often much higher in areas that are classed within our core 20% deprivation, although of course smoking is across the whole of society and has impact across the whole of society. So if we move to the next slide. So the core 20 for adults came out in 2021. This was then followed by the core 20 for children and young people. And this area is less developed because we've had it less within our arena. So you can see there are again 5 areas: focus, very importantly for us is the mental health focus. I know that as a Shropshire Telford and Wrekin, and particularly a Shropshire Council and Scrutiny, we have talked a lot about our children and young people and their mental health. And then we have the other areas which are specific around the asthma, looking at medication, use of medication, diabetes, making sure that we're seeing equal access to the latest technologies across our deprivation profiles. And then in epilepsy, really looking at the importance of having epilepsy specialist nurses and how more important that is for groups of individuals such as those with learning disability and or autistic people in their first year of diagnosis of epilepsy. If we move to the next slide. So there's two core 20+5s talk to the areas of clinical intervention. And I think as a group, we are more familiar with those. I wanted to share these 5 key lines of inquiry by the ASP. So each year, the local NHS will receive planning guidance from the national teams. And within the planning guidance, there's some very clear instructions around areas of health inequalities that we should be addressing across the system as providers. So those 5 areas you will have seen in the plan that Bernie and I worked together on in 2022, and also form part of the programmes of work that we report against. Each and every one of those areas are important in their own right. Data is particularly important because if we want to show that we're making an impact, we need to ensure that we're collecting accurate data in the first instance, and that's one of our key areas of focus, especially around ethnicity data. And the 5th area around strengthening leadership and accountability, when we have looked at both research in this country and also wider research, the areas that make the most impact in addressing health inequalities are those areas where there is strong leadership in relation to the boards that lead organisations. And as such, locally, myself and Nigel, as our senior responsible officer, have been working with our local provider boards and our ICB board to ensure that we are pushing that message about just how important health inequalities are across both health and our sustainability for our resources longer term, and the impact that we can have for everyone by looking at targeting those who are in most need. We move to the next one, please. So as we look at this visual representation, what I want to explain is that we have looked at progress against the actions people had put in their plans that they were going to take in terms of their projects that they had to address these areas. It's important to draw that distinction away from quantitative metrics, which will start to look at what has been the impact of those programmes. So I wouldn't want people to look at this visual and see red and think, oh, does that mean no impact has happened in that area? That is the report from the project managers, the people who are in charge of the projects. That has been their reflection on how far they have progressed the actions that in 2022 they had planned to undertake in 23-24. And if we move to the next slide. So you'll see there are a range of areas where some projects have been rated as green, others in amber, and we do have some areas where the plans that people had for those projects had not been fully realised within 23-24. Now, before I hand back to Mel, just to say that we are now collating the results of quarter 1 and 2 of this year, because these relate to the end of year report, which was March in this year. So there is actually within the paper that we have, that Mel and Phil have authored to bring to you as a health and wellbeing board, there is a suggestion that I will bring you at a later date the outcomes of Q1 and 2, and also update on how we're looking to work towards having a dashboard that gives metrics so that you can understand some of this information in a more quantitative form. Mel, if I'd like to hand back to you.
Lovely, thanks Tracy. So finally, Shropshire Council are looking to continue to move the Inequalities Initiative forward positively in the future. So we will continue to work towards the aims of One Shropshire and fulfilling the Shropshire Plan. And we are doing this already by taking a place-based approach with an early intervention and prevention focus, working in partnership across the ICS with Tracy and her teams, and also with our VCSE partners who are really integral to this work. On this slide, you can see the work. I suppose some of those approaches you can definitely see in the work that we've already developed. So particularly with community and family hubs across the county. So we currently have 5 of those operational hubs, with a view to further develop this place-based approach for meeting needs of local people, including those in our most rural areas. Sorry, excuse me. I would like to thank everyone who's contributed to this report, because as you can see, there is an enormous amount of work that is taking place. And on this slide, you'll see some of our targeted programmes for both the ICS and for Shropshire Council. So the colour coding represents programmes of work where we're already working in partnership. Sorry, excuse me. We do intend to report annually going forward to the Health and Wellbeing Board, and we welcome any questions from members of the board today. I'm just wondering if Rachel has anything that she might like to add just at the end, though, before we get to questions.
Thanks, Mel. Thank you, everybody, because as you say, this is not this is a real was endorsed by the Health and Wellbeing Board. There's obviously parts that are owned by individual parts of the system as well as collectively. I think the plan demonstrates there's some real collaborative work in there, from the work that's been done through the social task force, through the work around community hubs, the work that we've done to focus on places. I think this is the first time that we've brought this report to the board for an update. There's a commitment to bring regular updates through. It's not an end. This is a live document. There's a lot more to do. There's a huge amount of progress. Remember, this is from a point where perhaps there wasn't the focus on inequalities we'd have liked to have seen. So the fact that this remains a priority and is within all of our strategies is important, but we obviously have to, and the board will want to hold us to account to make sure that all of us are delivering, given the context that we've described, that we expect the situation to continue to worsen. The other point that we need to just draw to is around the metrics. So whilst we've got obviously been more qualitative metrics in here where we've tried to capture progress, there is also, and we come on to the ICP dashboard later, we are developing those metrics around inequalities that people can view. We can be transparent progress we're making in particular groups and not. That's an ongoing piece of work through some of the population health management work, because some of the outcomes that we measure on are quite historic. We want to be able to keep a real proxy focus on what is actually happening. So because, as we've said, we know that the cost of living, the impact of on areas such as rurality and others is really important for us to monitor, and it's very difficult to measure actually because of the small numbers that we often deal with, particularly in Shropshire. So I guess I just want to thank everybody for bringing this. We want to keep this very high up on the agenda, routinely monitoring progress, happy to take focus on particular areas that we want to going forward. Welcome everyone's support around this, as so this is the first opportunity to bring this before you, but again we would want to bring that regularly. And any questions, thanks to everybody for their involvement in bringing this forward. We can't let this slip. Going back to the Darcy point, the other thing just to add, I think, about Darcy is that we will review this in light of the recommendations that are coming through that the Darcy report, and I think that gives again an opportunity to chat about this. The final bit, sorry, just to mention, is immunisations in here.
we've talked about lots of good progress. Immunisations and inequalities is an area that we really strongly did well on in COVID. We had an absolute focus on delivering to our inequalities group, and that outreach model has been something we've built on for other long-term conditions, preventative approaches working in our communities. The numbers starting to show that some of that might start to slip. We can't lose focus on that. So again, that's a really important one for the board and for us to continue to again bring back up the agenda. Sorry, thank you.
No, that's great, Rachel. Thank you very much indeed. And I have to say that one of the great strengths about this work is the fact that it's working very hard to bring partner agencies together, work collaboratively. So important that we do that and that we continue to do it and do it very strongly. So I would very much like to see this coming back on a regular basis. I should say maybe in the new year now. But for the moment, I'll throw it open to questions, comments. It's a very good report. Thank you. Jackie.
Hi, Mel. Thank you. And I really struggled with this report and the plan, and I went back and I reread the inequalities plan and all the kind of targets and key performance indicators. So I really struggled to find out, as a Health and Wellbeing Board member, to scrutinise is so what? I don't understand what we haven't been able to achieve. So when those areas that we are grey or are amber or red, you know, why hasn't that happened? What's holding that up? With the green that have been completed, what's the outcome? How has that contributed? Because we clearly in 2022 had a set of what our key process measures were, and so I've really struggled to kind of line that up with the existing action plan. However, I do appreciate you've inherited this and you've had to do a lot of, and there's so much work going on, and kind of bringing that in, I've just really struggled, and I think the kind of sometimes you have to refresh the strategy in understanding what our inequalities look like in Shropshire. And like you said, they may have the same impact, but the drivers are different. We've clearly identified groups that aren't mentioned today, like LGBTQ+, Gypsy and Traveller communities. We've got a new growing population of refugees and international skills workers who are really struggling. And I'm sitting next to my colleague here who can tell you that domiciliary care is really in crisis, and the support of our skilled workers is very poor in that area. And you know, in some areas, and that's all I'm saying is, as a Health and Wellbeing Board member reading that, I struggle to find out how we've actually helped improve inequalities through all the programmes. Some are finishing, some are starting, some are opportunistic, but actually how do we get hold of all this work that we're doing to understand how that impacts on the overall inequalities? And, you know, previously this is a journey, and you know that, and I absolutely see that. But I think there's a bigger divide in Shropshire now between those who have things and have options and those who don't. And, you know, I just like a greater understanding of what we're doing to help that.
Yes.
Shall Rachel respond to that? I think the challenge, the first time we've presented this back. So what we've presented really is a list of, against the action plan, a bit in the same way that the ICS indicators we've done, is an indication of how we've been moved along in terms of summarising against what we said we would do. It's very much a kind of process measure, if you like, in terms of the progress against those. There is a full detailed plan which we haven't shared, which I think you need to see and have shared. What we've tried to do is summarise today to give you an indication of the direction. But in terms of the overall outcomes, that's the dashboard that I'm mentioning. The issue we've had is some of those haven't been updated. So the things that we absolutely need to measure are healthy life expectancy, some of those bigger trends, and pull bits from the cost of living dashboard, pulling bits from the ICP dashboard. It's a range of metrics. A lot of them are slower in being updated. So what we've done is update the work that's happening. It's been more difficult to track through to some of those other indicators. That being said, I don't think that's good. We are working on that, absolutely. Getting the data down to some of those groups that you talked about is a real challenge, but not one that I think
Tracy mentioned, not one that we're going to turn away from. So you will need to see that as, I think the board absolutely needs to see both the outcome measures as well as the detail of the process measures. So today was a bit about trying to get a judgment about how much you need. I'm really happy to share the detail of the plan, and I think it's what more do we need from that to be assured that we've got the right progress. Where we haven't got the progress, what more do we need to do? So if that answers some of the questions, really happy to give that detail, but also bring those high level metrics where we are seeing some progress, notwithstanding that we expect some of this will deteriorate because of wider context we're talking about. It's been quite difficult to map, but you're absolutely right. Saying that we had all this list of things and we're moving on some of them. I think what this report shows is that we haven't put this in a box, that we are all working towards it, that there is bits of work going on across the system around all of these, and that inequality is higher up the agenda, but are we actually delivering the outcomes we want to do? We haven't, all of that data isn't there, and that we need to see all of that. Does that help and do that answer?
Yeah, I think so. I get lost in the detail and appreciate that we're all kind of sitting here with our own experience of what inequalities look like, but we had a plan within strategy, and I just struggled to see the connection between the key process measures and things. So that's just yeah, I appreciate, and do you know what, it's just a minefield, and I really appreciate the hard work that's been done. I just think as a board we need some more high level, not more detail of what the impact and the outcome is. So yeah, but thank you for the work.
Yeah, no, and thanks, Jackie, and I totally take on board everything that you're saying. But yeah, I think as Rachel said, I think this report was just kind of to bring inequalities back to the table almost. Not that we had parked it, but because as you can see, there's lots and lots of really significant work ongoing. But I think this is just the starter for 10. And yes, we can certainly bring the impacts and the outcomes through the reporting as we continue.
I really support this coming back more often.
Right, Jackie, we'll bring it back, especially to you.
Oh no, not just especially with me.
Tracy.
Just really wanted to reiterate that there is a large healthcare inequalities plan that forms a subsection of this much wider plan, and that is the part that I'm really happy to bring back when I've got my Q1, Q2 reporting. Really happy to share that, share the statement of information which gives all the metrics that we are measured against. They do move slowly in terms of when the data is refreshed, but we are starting to see changes. So if I take the cancer, earlier diagnosis of cancer, and really looking at how we've had projects that have been working out with some of the communities that we've mentioned, we're starting to see changes in screening presentation, because that's one of the things we're wanting to encourage, the uptake in screening in some of our plus groups, and we can start seeing that. And we do have all of that, but that in itself would be a good half an hour, 40 minutes agenda for me to bring, but it's there. And Jackie, I'm more than happy to have separate conversations offline and share with you and talk it through, so that you can feel assured that we've got oversight of that work.
Thank you. Thank you both. Tanya.
Thank you, Chair. So fully support outcomes-based future reports. So thanks for raising that, Jackie. Just thinking about how this board can constantly bang the drum of Shropshire and what it's like for residents and providing services in a county like Shropshire, because we know nationally people don't understand counties like Shropshire. Right. And I just wonder, Rachel, through this work, how we can collectively, now under the new government, and I've read today that Helen Morgan has now got the portfolio holder for health and social care as in the opposition. I wonder if we can utilise this kind of new momentum around people understanding the real impact on our residents and Shropshire, because people don't get it. They don't see it, so therefore we don't believe it, and yet we see it because we work with people every single day. So I just wonder, as a board, if we could perhaps do some supportive letters to various secretaries of state, just kind of bang that drum. Then my final comment is around points of clarity. So whilst there's a national crisis in domiciliary care, which is all well understood, in Shropshire there is not. In Shropshire we have got really good care for people living at home in the community. So I wanted to make sure that the board understood that position.
Thanks, Tanya.
Just to comment, I fully agree. I think what I didn't probably mention is some of the recent reports that are coming out for me seem to be lacking in the mention of rurality and recognising some of the inequalities that we face around this, which the work that we've done as through the cost of living, and I know the next report we're going to talk about absolutely highlight. So whilst we, and as I said, it might be one of our plus factors certainly is within the work we're doing locally, but it's still not a theme that's coming through. But it's very difficult in the data because we know that the issues around small numbers, we've highlighted that's in the work we're doing around rural and digital exclusion is another example of where we recognise the difference in Shropshire. But I completely agree and happy to pick that up in terms of sharing some of this work more widely and circulating some of the previous concerns we've raised around policy needing to recognise that. And I'm sure that can share that around, so that could be a joint piece of work to promote that. And there's some chance of addressing.
Good, thank you, Lily. And then I'm going to wrap this discussion up.
Just a quick one from me. I completely agree with the conversation around outcomes, because for us as Health Watch, we really want to see what difference it's making and how it's feeling for people. And I know that Mel mentioned that you're working with people with lived experience. So I wonder if at some point we could have a conversation about what that means, what that looks like, and if there's anything that we can do to support it.
Yeah, we very much welcome that, Lynn. Thank you.
Great. Okay, I think very quickly.
Very quickly, just to say, I noticed on the ICB section as well, the rurality, I can't remember, Tracy, if it was yellow or greyed out, so I just wonder if we could do some work together on that rurality section and working with the ICB to really understand what needs to happen if it's not happening and how, and also what is, how we can do it together. There's I think, Nigel, you mentioned integrated neighbourhood teams. Yeah. What's happening in that way? What are our providers doing around the rurality element? And there are things happening, but I think it's maybe not recognised.
Right, thank you very much for that, Penny, and I absolutely agree with you there. Mel, Tracy, thank you very much indeed for your presentations. That's very helpful.
Thank you.
Well, hang on, have we got extras in mind? I thought we did.
We're in the
Do you want to? Are you happy to sit at the back? Do you want to sit up with them sitting? Where would you like?
There's two chairs.
We've got chairs there. Yeah, right. Come and sit there. Exactly. And okay. Yes, and actually, whilst all this is going on, I should have read the recommendations from the Equalities Plan, which are for members of the Health and Wellbeing Board to note the progress made in the delivery of the Shropshire and Equalities Plan to date, and for the Health and Wellbeing Board partner agencies to continue to work together to deliver the plan commitments and approve the forward plans and priorities outlined for the next 12-month period listed in this report. Receive yearly updates on the continued progress of the Inequalities Plan. I would actually like to see that near us 6 monthly, so that it actually falls into the cycle of the Health and Wellbeing Board. Yearly is too long, so we'll shorten that time period.
Very happy to support that, and we'll run through the outcomes matrix for that.
Yeah, because this is important stuff. Thank you very much indeed. Right now, I'm very happy to welcome for the next item. This is we're moving from the sort of fuller part of the agenda, of the Health and Wellbeing Board agenda, to the section where we tend to approve recommendations with discussion by exception. So we don't need to go through this report chapter and verse. It had quite an airing already. It's a very good report. It's gone certainly it emanated from the Health Overview and Scrutiny Committee. It's been to Cabinet. It's had quite an airing. So we have got quite a few recommendations coming from the report. But before we move on to those, it would be great if you would like to give us an update.
Right, okay. As chair of the Task and Finish group, rural grouping in health and care was such an important thing because residents' outcomes and experiences were not great. And actually what this report has done is bring together those things. So we're really tried to produce a report that would give that equitable outcome for everybody in the face of cuts in money and so on, because actually the outcomes could make a significant difference. I need to extend heartfelt thanks to officers, partners, witnesses, because what we did was when we took that evidence, we tried to triangulate everything we put in the report. So this is not what we feel, although we do feel it. It's actually the evidence that we gathered and is available in the report. And I'll take it that you have all read the report and so on. There are a few areas that I'd like to highlight. The impact of rurality on the access to health, and this fits exactly with what you've been saying. Yeah. And care services, including structural barriers and the need for a system-wide understanding of these challenges. And I'm afraid the National Health has not always understood that access around broadband, mobile phone signal, digital accessibility, all the rest of it. Notable inequalities in provision between rural and urban areas, higher cost and fewer services. Transport is a major issue and actually not improving at all. In fact, it's going backwards. And many rely on private vehicles due to the limited public transport. These impacts and their ability to access health and care services are fundamental to many rural dwellers. Poor digital connectivity that I've already talked about, which is a huge problem. And just being a councillor on the end of the green waste bin payments has shown me how very poor that is. And that's not a vital service. And anything that the NHS and the care system does is really, really important that you test it out and make sure it works. And recruiting and retaining healthcare professionals in rural areas is challenging, but as we've proved at Bishop's Castle, it's possible. You just have to do things a bit differently. The report made 14 recommendations to help address these. The first one is one I feel very strongly about, is that you fully adopt the rural proofing for health toolkit into an integrated impact assessment process, because some of the things that raises may not necessarily sit within NHS England's metrics. Ensuring that rurality and accessibility factors are key considerations when adapting and introducing new services or policies. Evaluating the impact of digitalisation, please do that properly, and recognising the vital role of the voluntary sector, ensuring sufficient understanding of its needs, because we're seeing more and more that the voluntary sector is struggling.
Good, thank you very much indeed. Good morning, everybody, and thank you for letting us come and talk to you. I wanted to say, just sitting there listening to what Tanya and Rachel just said, it is blatantly obvious that we understand rurality. We've got just over 1.1 persons per hectare, or whatever it is, sparsity in Shropshire. We understand that and understand the difficulties that means, but I'm quite positive that lots of people outside of the county just do not. They just do not understand the costs, the problems, the hurdles we need to jump over to get where we are. So, I think we're all doing the same thing, but what I really want to do is try and get some weighting to rurality. I still think that decisions made where to locate services, how to deliver services, are purely based on finance. well, not purely, but generally based on finance. And I do think there should be some weighting, some system that everybody follows to evaluate how an alternative method of delivering that should be given. And the weight should be on rurality. It should be on helping people to have the services that they need. You know, and we're putting services in Shrewsbury. I live in the north of Shropshire, right on the Welsh border. Heather lives on the south. It could take us an hour to get here, you know, to access some services. There's 5,000 people in each of our villages or towns. There's 5,000 people travelling down these very small, narrow roads to get somewhere. So, you know, there's all sorts of issues. Do we deliver the services locally, and how do we do it in a small money and costly? So those are the things that I really want to formalise and get people to understand that they need to consider that making any decision whatsoever. So and that just came to me from sitting there listening to your conversation. So thank you very much indeed for prompting me on that.
Can I add something to that?
Sure.
I think the most important thing is we measure actually the difference it's made to residents, because it's their feeling about what's happening rather than finding suddenly they can only have their blood tests in Shrewsbury or whatever. It's their experience of what the Health and Wellbeing Board is talking about today and those inequalities. That's just one example. So you can have lots of numbers, you can have reds and greens on maps, you can do all of that, but what matters is what our residents feel or see.
Yeah, so we need to be able to monitor it and actually prove that we're progressing and we're doing the right thing. Anyway, I'll read my little brief that I'd written prior to coming. As the chair of the Health Overview and Scrutiny Committee and a member of this Task and Finish group, I'm pleased to say that many of the recommendations from this report are already beginning to be adopted, which is great news. This adoption not only demonstrates our commitment to improving health and care services for rural communities, but also highlights the potential for joined up cross-border working to support these activities. You know, we're on the border, we can do lots of things with not just Shropshire, but our neighbouring counties. This collaborative approach is essential for addressing the complex challenges faced by our rural communities, which we've just mentioned. The HOS Committee will continue to monitor the progress of all 14 of our recommendations so we can establish their effectiveness in supporting the delivery of services. Thank you all for your attention and continued focus on improving health and care services for our rural communities. And we, as HOS members and members of this report, are very interested to listen to any comments and suggestions that you may have. We're happy to take any questions. And really, we just want to know what actions that your organisations have taken and what actions you haven't taken because you may not be able to do so, and what those reasons are, so that we can address them. Are there things that you would have liked to have done but you haven't done because of? So to us, although we've completed this report, a year ago, we're not letting go of it. It's an ongoing report. It's live. It's changing every day, and we want to make sure that people actually use the report and it is beneficial. And if it's not being used, we'd like to find out why it's not being used and how we can make people understand and get it used. So if you wanted to give some comments now or email us or whatever, I'm very happy, or would be very happy to consider those reasons. Thank you very much indeed once again for today.
Thank you very much, Jeff. Lynn.
Thank you, Celia. A few things from me. For Health Watch, health inequality is a massive deal, and of course rurality is that too. But we are a very small team, and with all the will in the world, we don't have the capacity to engage with the rural communities in the way that we would like to. You know, we've got one engagement officer covering the whole of Shropshire. And so I would like to say that, you know, we'd be happy to work in partnership with other parts of our system to get this lived experience from people. But I think the other thing I was going to mention as well, within our rural communities, we do have a range of demographic groups. And I worry that there's quite a number of people whose voices continues to be unheard because there might be a small group within some of those communities. Looking back at the Core 20 and all of those things. So I think we have got a huge amount of work to do to really understand this experience from all people who find themselves living in rural communities, and what they think would help make a difference. My concern, I'm not a politician, but my concern is that as part of the NHS plan, it was always about bringing services into communities, but the reality is that there is not the money to do it. And so it isn't in our gift to fix some of that. So I think, it is a massive issue and it's something that we think is really important, but I'm also frustrated about the lack of difference that we're able to make.
Thank you. Nigel, perhaps you could reassure Lynn a little bit.
I may or may not, but I think what I suppose, and Jeff and Heather were kindly able to join an integrated care board development session that we had 2 or 3 months ago, and I suppose just responding to Jeff's request and challenge in the nicest possible way, I think. Like some of the other themes that we've been talking about, step one is making sure that everyone is really, really aware that this is there. And there's some really good quality framework there with the toolkit, and we can properly use it. And personally, because I live in a small rural community, then I'm quite committed to this too. So I think making sure that through the Integrated Care Board, all the chairs, chief execs and key other colleagues within the Integrated Care Board, that was really important. And the Integrated Care Board is not just NHS, it's more as we know. I think the second bit is, as a theme, again, as we've heard with what we've been talking about this morning, it's not standalone, it dovetails with others, doesn't it? And, Cecilia made that very point. And I think that's also really, really important to the overlap. Whilst Tanya was talking about something ever so slightly different, of course, it just reinforces. And I think with the work that we're trying to do, albeit healthcare inequalities, dovetailing with wider inequality and using that, I think that's really the part of it. We'll talk a little bit later about whilst we've got the metrics about how we've tried to refresh the integrated care strategy for our system and how we build upon that. I think the only other, two other quick things. I think the penultimate one is we are about to, I know it sounds a bit daft, going into the planning round for next year. Quite shortly, and I know our head of commissioning, strategic commissioning, is already looking at how we refresh what's called the commissioning intentions, and so we've shared this with her because I think this is one of those themes that can weave in depending on how you try to look. That's important, and again, and other colleagues will be more au fait and be leading that work. But I think whilst Tanya, you talked about raising the profile, the work that we're doing as part of Marches Forward, I think is really quite important in that regard, because we've got 4 local authority areas which really do share that sort of that focus and those challenges, and so I think that continues to be a really, really important vehicle for us.
Good, thank you.
That's helpful, Nigel. Thank you very much, Jackie.
As your VCS lead on the health and wellbeing, thank you so much for this report. It's just brilliant, and I've seen it before, but thank you for recognising the value of the sector and the challenges it faces. Thank you to Shropshire Council for its continued support and recognition of the VCS and how important it is, and just a welcome on the wider ICS, the ICB, and the commissioning intentions of how wider the system can support the voluntary sector, increasing its capacity to carry on its great work and be part of this system.
Thank you, Jackie. Rachel.
Yeah, I think a couple of things to pick up. I think one, definitely the marches, I think is really important.
Yeah,
back to Tanya's point, as Nigel said, we have shared the toolkit with them, who have some of them have not. Some members that we were talking about from the health subgroup hadn't seen it before, really welcomed it and really positively supported. So I think that's the commitment to support the continued adoption of that. But I do think that links really strongly to how we get a bigger voice around some of this. The challenges that we were talking about around health and care in that group, when we had the conversation, we absolutely mirrored everything we said. The approaches that we're trying to take
against all odds to get care into our community. The work around hubs and others was again mirrored across. So the way that we have to address healthcare in more rural areas is very different often to what we see in urban areas, and that was felt strongly. So I think that perhaps is something about how we can all collectively raise the profile and get the voices heard. And again, but what difference does that make? I think the critical question for me that's come out of today, and I think it's a really fair and really important challenge, is around not only how do we measure some of this, but particularly the lived experience and the voice. And it's often more difficult to get, but between us all, we can get to that much better. What strikes me is we're working with a lot of these communities. There is still gaps that we need to address, but actually we are moving in the right direction. But what more do we need to do, given we've all got limited resources? So who's the best placed in those communities to make sure we get not just messages around suicide, but all of those other important messages? I think there's a bit more we could perhaps do, maybe working with through SHIP to join that up a bit more, is what I've recognised, and that comes to the profiles we're going to talk about later, actually the dashboards again, how do we get that voice in there? But yeah, and the other thing I just wanted to mention, one of the points you rightly raised around digital. There's a lot of work, if I kind of put my Shropshire Council hat back on a bit more, one of the work at the heart of the customer programme that we need to look at is the recognition that we need to recognise digital exclusion and try and mitigate some of that. But actually you can't always, how do you do things differently? Is that upskilling people? Is that the hub work to get out into those communities? For a county such as Shropshire, it can't be one or the other. And so we just need to constantly be striving to, for those who can access technology, make it available so people can get it like the Green Book. But if you can't, then how can people help you to do that, and how can we upskill people? Again, some of that we're doing as a council, but actually we're doing that collectively again through some of the digital exclusion work and recognising that. A lot of these are very much starting. I guess the question is, how do we keep the momentum going and make sure we maximise resources when everybody's so stretched? But a couple of things that you've mentioned in there, the rural toolkit absolutely endorsed, and we've started to use that. The digital work has begun, but again, what more can we do? And I think the point around the marches will take forward collectively, because that's really powerful, and the indicators. I'm going to take that away and work with the team very strongly on that. I'll be messaging Jess throughout this to make sure we work with colleagues to pick that up.
Thank you very much, Rachel. Can I thank you both very much indeed? Sorry, for coming. It is a great piece of work, this, and I mean, personally, as you know, Heather, I really welcome it because of my position, like yours, as a division councillor in a very rural area, and the frustrations that we have in trying to get help to the right people at the right time. So I think we are very much focused on this, and we will continue to be very much focused on this. And I'm delighted that the Rural Proofing for Health Toolkit is already being adopted. That's great news. So perhaps can we ask you to come back again next year? Perhaps let's just see what progress you're making. Let's keep up with this. I think we need to. I'm sure you'll be reporting back to HOSC, but I think it's important that we keep this connection with the Health and Wellbeing Board. It's very important.
Agreed.
Thank you so much. So we have some recommendations for this item, which is that the members of the Health and Wellbeing Board note the report and recommendations of the Task and Finish group attached Appendix A to the report, and from the 14 recommendations that were outlined, the Health and Wellbeing Board are asked to endorse those which relate to the board, which are included in section 7 of the report. We will certainly do that. Thank you very much.
Thank you once again for listening to us. Thank you very much.
Sure.
Keep up the good work.
Good. Thanks. Right. We have another report now, discussion by exception, and we've got quite a lot still to get through, and I am so far behind time that I'm absolutely blushing. But I do apologise. Right, we come first of all to Jess Edwards. Welcome, Jess.
Morning.
The Children, Young People's JSNA update. It is a massive report, this, Jess.
It is.
You've not to take us through it line by line.
No.
Thank you.
So we brought these two chapters to the Health and Wellbeing Board in April 2024, so this April just gone, for its first review and feedback. And we went away with those comments and took it to the Early Help Partnership Board, SHIP, and some other forums as well. And this is really a joint really good example of a really joint piece of work with the system and our partners. We've made recommendations. There are 15 of them, and within the document, which I won't go through, there is a summary slide deck that goes alongside each chapter, so they're a bit more digestible. And in there's a table which shows each recommendation, what we're doing now, what we intend to do, and then the governance around that. And just to say that Public Health will be coordinating the reporting to the board of Health and Wellbeing Board of progress of those actions and recommendations. So it's just for, I'm assuming that's been read. I know it's absolutely huge, and we have 3 more chapters coming in November to show you and get feedback and recommendations approved. But it's just for the board to endorse the recommendations we've made around the 0 to 4-year-old age group. They're quite varied. Would you like me to go through them, or do we assume they've been read?
Can you whip through them?
Sure,
I mean,
yes.
I've got a lot of recommendations here, and I note particularly the emergency admission of 0 to 4s.
Yes.
Just go through them very quickly if you could.
Sure. So just to point out as well, in the first chapter, which is population context, there is a focus on rurality and inequalities off the back of the conversations that have just been made. And we are working really hard to integrate that as a golden thread throughout each chapter for each age group. So you'll see it pop up all the time. So we always put a reference to it. So the recommendations, the first one is around supporting partners, family members of pregnant women to stop smoking and reduce the rates of pregnant women smoking at time of delivery. Second one is to continue monitoring child and infant mortality and adjusting action plans as required to ensure those appropriate mitigations are in place. The third one is around emergency admissions of 0 to 4-year-olds. That is that data is there's caveats to that. So they're all in the data and in the slide deck. But essentially, we don't have a certain provision of care for same-day emergency care. So a lot of the 0 to 4-year-olds will go to hospital, be admitted for less than a day, so their length of stay is 0. And that looks like we're having lots of admissions, whereas really it's because we don't have that provision of same-day emergency care. So that's what our ICB colleagues informed us of, and we're working hard with them to interrogate that data to make sure that's what's continuing to happen. Number 4 is increased uptake of pregnancy and childhood immunisations. Number 5, increased breastfeeding rates at 6 to 8 weeks, which we know is rising at the moment. So we are doing better than we were. To increase and monitor the number of families accessing mandated contacts, there's all your health visiting metrics. And again, we're doing a big piece of work around the data quality for that data from Shropcom, because we know there's some discrepancies, so I can feed back to the board next time. To ensure the cost of living support and for health and wellbeing is promoted through all services, including those uptake of Healthy Start vouchers. So we perform quite well with Healthy Start vouchers, but we can always improve this. We're not at 100% of uptake, so we're at something like 94%. And we do also have the cost of living dashboard, which we're bringing here today as well for approval, which supports this recommendation and monitoring that impact. Number 8 is to reduce the number of 0 to 4s whose parents use drug and alcohol and become looked after, and also increasing those parents who receive support at the earliest opportunity. So there is a action plan in place for the drug and alcohol misuse group, and that features in there as well to increase that uptake of support for parents that are in treatment. Number 9, we're getting there, to reduce the number of 0 to 4s living in households where domestic abuse occurs, and supporting the workforce to identify perpetrators, to support them for behaviour change programmes. So that one is also being dug into. The data has been interrogated as part of the domestic abuse needs assessment, which Wendy Borman is leading on. So that links in with that domestic abuse board. Number 10, for all health and social care agencies to ensure they assess the mental health needs of the child, mother and family and signpost relevant services and intervention. And 11, to develop women's health hubs across Shropshire, aligning with the community and family hubs work. We know there's a lot of work going on around the hubs and supporting children and women and children's age 0 to 4s, and that's where we have those health visitors that are in the hubs doing those extra mandated contact clinics. Number 12, to publish the best Start for Life offer to enable families to access information around services and support. Number 13, to increase awareness of early help and prevention offers to support families and prevent escalation. We're doing a lot of monitoring around early help, and we always have done, but particularly to look at the impact of the hubs around preventing that escalations. That feeds into this part of JSNA. And 14, to continue to monitor the level of children who are overweight or obese at reception and deliver early years actions on the healthier weight strategy. So that ties in with our healthier weight strategy, which we published. And then lastly, to engage stakeholders to inform delivery recommendations and also have accountability and ownership of those. So those are 15. I know there's lots of them, but this age group, we have a lot of service provision around them, so it's a bit longer for this age group than it will be for the future age groups we bring to the board.
That's important stuff. Thank you very much, Jess. Does anybody have any questions, comments? Penny?
Just very quickly, Seth, just to highlight that the recommendations and the work that's ongoing are also cited and worked through at the Early Help Partnership Board. And there's significant crossover with a lot of our transformation programs, but as mentioned in the recommendations, the development of the community and family hubs and the integration work and the integrated neighbourhood team. So there's a huge amount of crossover work is underway.
That's good. Full speed ahead. Thank you very much for that, Jess. I don't think anybody else has a hand up. So shall we rattle on, Jess, to the cost of living dashboard update?
Yes, let me just get it off my screen. So hopefully the link worked for everybody and you could view it, but I put screenshots in just in case it's not available through different laptops and IT systems. So this was developed, the ask originally came from the Social Task Force and was developed to assess the needs of our population in terms of cost of living crisis. It again has been a really great example of a joint piece of work. We've had data from many of our partners, including the voluntary sector, and we continue to collect data from our partners as we go. So it is an iterative product. It won't be static. Our intention is to publish on the website and to promote this tool as something we can all use as a partnership to guide our needs and our decision making around cost of living. So in the report itself, one second. I've put in some screenshots around what it contains. So we have household spend, employment and earnings, housing, and health and society. We have some gaps still. We do need to put some more information in there, but we also do have an employment JSNA dashboard that sits alongside this that supplements and gives us lots of information around the job sector, statistics, and also employment. So together they're a really good suite of tools that can be used, especially for the Social Task Force group, to inform their delivery and action plans. So I won't say much more on that, but it's just for the board to have a look and see if there's any feedback or if you're happy to approve for that to be used on the Shropshire Council website.
Does anybody have any rooted objection to this going onto the website? It seems to me that it's a very sensible thing to do. Any comments? No. Okay, no, Jess, that's fine. Thank you. The recommendations for the board to note the contents of the update, and obviously that point about it going onto the website. Happy with that too. So now we move on to the ICP dashboard update.
Yes, Rachel, do you want to give an introduction to the PHM programme of work, and I can go on to the metrics part of it?
Thank you. I suppose so. This is part of this section is part of our integrated care partnership update section. Yeah. I think I'm going to come to Nigel in a moment too, because we need to update in terms of the integrated care strategy. I think it's certainly the theme of some of the conversations today has been about how we measure and monitor outcomes. I think, as I said before, actually my reflection through all of this and note didn't to be taken away is how we make sure in all of this, that firstly we put the methods in place to monitor some of the outcomes as we're demonstrating through some of these framework that we're bringing forward. And that's some of the work that the population health management group are doing, that you'll see. So not just developing outcomes, monitoring what difference are we making as a partnership, the integrated care partnership, what difference are we making through our inequalities work and others. Some of these are very high level metrics, and what this has done is given us a first attempt at trying to bring these together. But I think the theme for me very strongly is how do we get more granular in that information? How do we, once we've collated that, start to add the insight about what is this actually telling us? And a big part of that is bringing that lived experience in, because are people really feeling the difference, which I think is a fair challenge that we've had through all of our conversations, and we have to keep holding together. So I think notwithstanding that, the dashboard is one of the developments and we're looking for kind of comments and feedback on that as we've tried to pull together at a high level some of the outcomes we'd expect to see, but bearing in mind that we have a suite of other indicators that sit under this and are overseen by various boards. The idea is that we can then monitor, are we making a difference? Some of these don't move quickly.
But we need some high level outcomes about what are we here to do, what does our strategy tell us that we're going to be doing, and how do we then start to move some of that forward. So that's in terms of the broader context and why these were pulled together. This is a development piece of work that's been undertaken by partners across the system in terms of those metrics. As I said, notwithstanding the more qualitative, this sits as part of this strategy, which is currently being refreshed. And I don't know, Nigel, did you just want to mention that at this point as well?
If that's okay.
Please do, Nigel.
So I think, and thanks, Rachel, and Jess and other colleagues, as Rachel said, have been absolutely part of this. So hopefully the Health and Wellbeing Board will remember that as the ICS came into being nearly a couple of years ago now, then one of the tasks was to try and look to produce a systems integrated care strategy. One was done, and there were some good elements in that, but I think a few of us felt that it was ripe for refreshing. It was ripe for probably turning into a bit more of a professional looking document. And also that even in a couple of years, and especially since post-COVID and with some of the analysis and great work, it was an opportunity to really refresh it. So with your permission, what we want to do is share that draft strategy document with Health and Wellbeing Board members. The ICP meeting is scheduled for the end of October, so we genuinely have got time to seek everybody's input. The narrative has been updated. We've got an introduction, and thank you to Rachel and Helen at Telford. We've got an introduction from our two leaders, which we also think is really important. The outcome data, as Jess and others have done, and actually Telford and Regan have updated some of their Health and Wellbeing Board strategy elements. That's been included. A section's been added on the provider collaboration. We've strengthened the voluntary and community sector elements. So again, it'd be really useful, Jackie, to get your feedback. So if we may, we want to share that because we think it's a really important strategy document. And again, just to reinforce the fact that it's not the plan, because that's the joint board plan, it's the strategy itself. I think the other bit, just as and Rachel just mentioned it very, very briefly, Lord Darcy's report, which is on the state of the NHS in England, is often an important feature, and I'm sure us in the NHS are certainly expecting change in that regard and a wider 10-year plan. But actually, when you look at the challenges for the population, challenges on services, the importance of community-based services, the importance of focusing on prevention, actually, we don't feel that our strategy is far wrong here. The work that we've been doing, looking at neighbourhood teams, with the joining forces together with different partners, and a focus on how we do things better, even just what Heather and Jeff were talking about. So actually, whilst Darcy and some of the really significant changes may come, and Lee and I share some of your reticence on some of that, I don't think our strategy is far wrong, but again, it'd be really good to get feedback. Thank you.
Thank you very much, Nigel. Any input? Anyone? Jackie, you got any comments?
We'll share it. You haven't seen it yet, so it'd be great to get
You haven't seen it?
Yeah.
Chair, can I?
Yes.
I just wondered, Jess, you haven't had a chance to say yet on the kind of the KPIs and looking at the outcomes framework, but I just wondered if there was an opportunity through the strategy and the KPIs to really embed the inequalities and the rurality that we've been talking about today. And although there's connections within what's in here, it's not explicit, I suppose, from looking at that. And I just wonder if there's an opportunity to do that.
Sorry, it was just the only comment I would make. I think we do need to. We've got to look at the triangle of all the metrics. So it's how I think you're right. How do we pull maybe an overall metric through? But there's the detailed metric around the inequalities dashboard should absolutely make sure it's got all the rurality, and it should be in each of the other dashboards. I'm not probably explaining it very well. But
it's at what level it's
the triangle of metrics. You're absolutely right. We need to go back and review and make sure we've got lived experience through all of that we've got the rurality is strongly enough heard. And then it's kind of that triangle, which this is a really high level, but that's notwithstanding, there'll be lots of other, I'm not explaining that very well. People are looking at them, no, but you're right, but we need to just check that that's there. And do we want a high level metric in the dashboard? But then I would expect lots more in other parts of the
dashboards that have been able to be here. I'm going to be quiet now. It's been recorded.
Thank you.
That's my explanation better than me.
We're all with you then.
I understood, Rachel.
Absolutely.
I'm going to take us back, if that's okay, to the JSNA for CYP. And I think it's a great JSNA, Jess, but I think as board, we do need to look at some of the stats that are in that JSNA, because Shropshire's children and young people are below statistical neighbours, below West Midlands and below the England average on many areas. And I'm a bit concerned we've kind of skipped through that without really debating that and thinking about what actions we're taking as a health and wellbeing board to improve the health outcomes for our children and young people in Shropshire. And I'm conscious of time, Chair. I wonder whether or not, as a future agenda item, we specifically look at this, because if board members do spend time looking at it, it is quite concerning how much below we are. And I know it's 22-23 data, and no doubt we're waiting for the 23-24 data, but there's some worrying trends there that as board we really need to be sighted on and thinking about what we're doing about it.
Yeah, I absolutely hear what you're saying, Anya, and I think what we should do is actually make that an item on the next agenda. If we can do that, because I absolutely agree with you.
Yes, I was just going to build that point. So obviously with all of the JSNAs that we're doing, including actually the place-based one and others, the point of doing this to give us that really strong evidence base around what's happening currently, what's happening, and therefore the recommendation should come out of that. And I think it's time to say, then how do we hold ourselves to account? Because it's not, we've provided this data, we've done this analysis, that should link back through to all of our strategies, our commissioning plans, the actions that we're taking, and I think there's absolutely some impact. So are we doing that? And I think that's been very much the theme of today, hasn't it, in terms of all of our plans, all of our work. Are we making the difference? Are we doing enough? And if not, why not? Because this should be the starting point for all of our evidence base, the commissioning intentions that we've got in terms of children and people. Are they reflecting as a system, or as a local authority, or are plans reflecting this? So the same for all of us. That's just, I guess, a reminder of the purpose of it. I think it's a really fair challenge.
I agree with you. And I think we should bring that forward if we can. Darzi, I'm not quite sure whether to be worried about Darzi or to welcome Darzi, insofar as Tanya said before, there are a lot of people in government who just simply don't get Shropshire. It probably isn't quite the same for Telford, but there is this tendency for people to make assumptions about rural areas which actually are incorrect. And I'm just hoping that whatever comes out of Darzi and whatever action government take is not going to try to package us all such that, we don't have the time or the leeway or the money to concentrate on those elements of our own health and well-being, which are particular to Shropshire. I just do hope that there will be that recognition of difference. I don't know whether you have any sense of that, Nigel.
I don't as yet. I think there's been quite limited discussion within the NHS circles, because it's literally over the past few days.
Yes.
I think the only two things that give me ever so slightly positive thoughts are, firstly, it reinforces the role of integrated care systems, and therefore as the vehicle, so there is still that distributed leadership and responsibility. So this is not an attempt to perhaps do a command and control from too far up the chain. And the second one is a focus and a reinforcement of the importance of community-based services and prevention is the vehicle and the priorities we've been talking about, and you can't do that universally, because your populations will have differences. And I think all the work that Jason talked about, a range of those. So that's my personal views rather than seeing it. But that certainly would be what I would be lobbying if asked, and the messages I would be putting up, Jane.
Yeah, right. Okay, that's helpful. Thank you. Right, any more on this? Because I'm conscious that No, we're not doing too badly. It's really half an hour late. Sorry about that, everybody.
Yeah, if I may,
Yeah.
so just in conscious of time, so if we are able to kindly share the integrated care strategy, if perhaps with any comments on that alongside the work that Jess has done on the outcomes, because they are part and parcel of the same, this is what we want to try and achieve and show. Would that be okay?
Yes, I think that's a good idea, because this is not something that I think we can all do today. I think this is something that needs considerable thought. So we have recommendations to review and comment on the outcome metrics, including in this report, which we have. Note the progress to date against the ICS and Health and Wellbeing Board strategy outcomes. Consider any additional or amended outcomes for consideration within the framework of the board, and that we'll do some work on. Yeah. Okay. Everybody happy with that? Thank you. Okay. Moving on. Naomi, back to you. Jeff, thank you very much indeed.
Thank you.
Naomi, back to you for the Women's Health Hub Progress Report.
Thank you. I work on the basis that people have had the opportunity to read the report and the attached presentation. And I just wanted to bring highlight 4 kind of key areas. Firstly, the key programme milestone was reached with the opening of Highley as the first Women's Health Hub for Shropshire, Telford and Wrekin. I think that really talks to a lot of what's been discussed here today and the drivers behind that, including kind of rurality, lack of access to women's health care, most particularly, and I suppose also the kind of health belief model mostly that's been experienced in that general area by the patient population. It's also important to mention and bring to everyone's attention that this piece of work is embedded in the development of Shropshire's community and family hubs integration and the integrated neighbourhood team. So it doesn't stand alone. It is very much embedded in that approach that we're taking as an area. We have released an expression of interest to all of our primary care networks to support the development of this work. It's been very positively received, but the 2 core elements of those expression of interest are around the expectation for collaborative community focus from our general practice colleagues and a specific piece of work and additional funding made available focusing on inequalities. The closing date for those expressions of interest are Friday week, so the 27th, but we're having really positive conversations with the clinical leads and associated GP practices around their approaches. The last area to note is the last page of the presentation attached to the report highlights the programme enablers. So I think what it does, it gives a good insight into how this work is kind of cross-cutting across our system. So again, a reflection on the fact that it is not working in isolation and we are represented and being supported by various system programmes of work, including the work around cancer and the LMNS. I have nothing further to add unless anyone has any questions at all.
Does anybody have any questions? Yeah, any, and then Lynn.
Can I just say thank you to Naomi for taking on this piece of work, because it is an example of true system working. It is across Shropshire, Telford and Wrekin. It has got a focus on inequalities, and it really isn't easy because it is working across the whole system with the whole range of people you could imagine who should and want to be involved in this kind of work. So making really good progress and hitting the timelines for getting a hub up and running by July was absolutely fantastic and no mean feat. So thank you very much.
Thank you. I'm just going to mention again the piece of work I did a couple of years ago around menopause, and I had a very interesting conversation with the Muslim community in Craven Arms, who were desperate for information and someone to go and speak to them about what to expect with perimenopause, menopause and postmenopause. And at the time I wasn't able to find someone who could do it. And that is an example of a community who are very much where they live. They don't have their own transport to get out of Craven Arms to access that, and that is where services really need to go and speak to them. So I think just bearing in mind that sort of proactive approach to reaching out to communities for whom English isn't their first language, but they have all the same questions as everybody else.
Yeah.
And they just don't know who to ask.
So I think two things on that. I think it would be really helpful to bring that to the steering group. I know you're a member of the steering group for the Women's Health Hub, so it'd be really great to bring that next week and raise that. And also to assure you, so we have had some initial responses to the expression interest. And one of the approaches is very much around the inequalities piece, about talking to more isolated communities within already isolated communities.
Yeah.
So I think that the outcomes and the recommendations of that report should be shared with the PCN, with the associated PCNs, and to use that as an enabler to that. So more than happy to do that.
Nigel.
It's only a very quick one, and that Naomi may well be aware of it, but we had a briefing and report by the ICB cancer lead on Tuesday, because it's Gynecological Cancer Awareness Month. And there was some really important literature, really good literature, wasn't there? So it's really just to put it on the board's alert the board, but hopefully that's, I know it's obviously the Health Hub will be one part, but it's really about cascading it through all sorts, including GP surgeries and others, but just felt relevant given the topic.
Absolutely, thank you, Nigel. That's very helpful. Right, do we have any more? Yes, Tracy.
It was just to say, and I hope that Naomi didn't mind, I was at a meeting discussing around probation services and women who are in probation services, and looking at how we can be more integrated in health with that. And I have actually passed their details on to you, just to bring that in and talk another group of women who perhaps are marginalised in society and how we can help their health. Thank you.
It was just again to reiterate the thanks that Penny has already said to Naomi and colleagues for this work. I think that and the benefit of this for me is the absolute alignment of these programmes and the constant seeking out, a bit like we heard with the suicide, of those groups that was trying to get into those populations. But I think it's the alignment that's the critical. We've done these in isolation before. It was very easy for this to be done separately, and actually the benefit of the bigger value add for everybody for those populations as we're bringing together. So it's just to highlight that and how we keep building on that approach. It's not easy.
Well done, Naomi. Thank you very much indeed. Okay. Any more points? Okay, we have some recommendations here. For members of the Health and Wellbeing Board to note the content and programme updates and reflect on the progress to date. Note the first programme delivery milestone was successfully met. Brilliant. Note the work reflects the delivery area of Shropshire, Telford and Wrekin. Excellent endorsement of the approach and discussion. Thank you. That's a great piece of work. Okay, now we get to the chair's report. And I have to report. Consolidation of pharmacies, but I'm actually not going to read them all out. There's quite a few of them, and I don't think we need to, and the core hours are changing and whatnot. But I'm just going to say that the pharmacy update will be published on the website after this meeting. But I would just also note that it is quite concerning that our community pharmacies seem to be struggling somewhat. And I think that's particularly in a place like Shropshire. I think that is, I think that's most unfortunate because we really need them. Lynn.
Just to inform the board that our current piece of work at Healthport Shropshire is about pharmacy and people's experience of accessing pharmacy, particularly with things like Pharmacy First. And so if you could promote that survey, which is on our website, that would be really helpful. And we're, capacity allowing, we're also hoping to go out into the communities and speak to the pharmacists themselves.
Yeah.
And to do this piece of work, we've engaged with the local pharmaceutical committee.
Good.
So that they're aware of it, because I was particularly concerned that a lot of things seem to be pushed towards pharmacies, and yet whether or not they're prepared or equipped or have the capacity to deal with so many things is something that we just want to uncover and find out people's experiences of using that.
from the news this morning as well.
I think just that is I think just from what we've been, that's a fantastic piece of work. We're restarting the pharmacy needs assessment in January, so that's really timely in terms of that providing the fundamental evidence base about what people are saying. Also to bring that back and state that's I think that's really we can push it as far as possible.
We must keep an eye on this because this is really quite serious. Right, now we just have a report for information only, which is the ship update. If you want to say anything.
Thanks, Chair. Nothing further to add. It's a regular report just for the board to know progress and priorities of ship. Thank you.
Great, thank you all very much. Somehow, yes, Lynn.
I would just like to ask the board if it was possible for me to bring our cancer report to the next meeting. The report was, the engagement happened in the first 6 months of the year, but because I haven't been in work, the publication's been delayed, but I'm currently working on the report, and so I'm hoping that it will be available for the next meeting.
Yes, thank you very much, Lynn. I'm sure we can look at that. Louisa, I think we can.
By all means, we can discuss that. I think it's coming to the next ship meeting, isn't it? So just we'll work it between the two.
Yes. Okay, that's fine. Thank you very much indeed. Okay, I'm now going to close the meeting triumphantly, only 15 minutes late, which I do apologise.
No more blushing.
So thank you very much for your attendance. Thank you to all of you online who've attended. I think this has been another full and very helpful meeting. Thank you.